Thank you. So welcome back, everyone. And the second part of this session promises to be every bit as good as the first. And it's my great pleasure to introduce my colleague Kostas Dimopoulos, who works in London at the Royal Brompton Hospital and has written really the seminal work on end-stage pulmonary hypertension and congenital heart disease in the context of Eisenmenger syndrome. So Kostas, welcome, and thank you so much in advance for your contribution.
Thank you very much, David, and thank you, Michael, for the invitation. I'm going to talk about this big topic in less than 20 minutes, so I apologize if I miss a few topics, a few aspects of this big topic. But just to reiterate, first of all, that pulmonary hypertension in adults with congenital heart disease is not just Eisenmenger syndrome. We have patients with pulmonary hypertension and congenital heart disease within all 5 groups of the pulmonary hypertension classification, the international classification, going from group 1 to group 5. Of course, group 1 is the group that has attracted the most attention. It's pulmonary arterial hypertension, but the biggest probably group of pulmonary hypertension in adults with congenital heart disease is the post-capillary group, group 2, where we have patients with left or systemic heart disease causing pulmonary hypertension. There are, of course, patients with lung disease. There are patients with obstruction in the pulmonary arteries that could cause pulmonary hypertension, and miscellaneous causes for pulmonary hypertension. Now, focusing on group 1, pulmonary arterial hypertension and congenital heart disease, we know it's a very wide spectrum of conditions. It varies from minor rises in pulmonary vascular resistance and in the presence of a possibly a large left-to-right shunt, but as disease progresses, the shunt diminishes, the resistances increase, the histological grade increases, and then we can get to the extreme end of the spectrum, which is Eisenmenger syndrome, with usually a bidirectional right-to-left shunt. Within PAH, indeed, there are 4 groups that have been proposed and which are clinically very relevant. We have group 1, which is the extreme end, as I said, Eisenmenger syndrome. Group 2 is those patients with less severe pulmonary hypertension, pulmonary vascular disease, and still left-to-right shunts. We have patients with small defects, in whom we wouldn't expect that the pulmonary hypertension would develop, but still it's there. And then finally, a group that is becoming ever more prominent is the patients after corrective cardiac surgery. Focusing on Eisenmenger syndrome, just to remind ourselves of the first description by Eisenmenger, then reproposed by Paul Wood in his seminal book and papers back in the 1950s, but nothing much has changed since the first description of Eisenmenger in 1897. We have patients with shortness of breath, with heart failure, with hemoptysis, and who die earlier than their peers. So this is very familiar to us following patients even nowadays. What we think often about Eisenmenger patients is this kind of patients. This is a patient, young patient without Down syndrome, but with a complete atrioventricular septal defect. You can see here the common AV valve, but what is important is the very hypertrophied and I would say well-functioning, at least systolic function is preserved of the right ventricle. And you can see the bidirectional shunt here. It is bidirectional, mainly right to left, but it's never just right to left, even because of the difference in timing in the contraction between the RV and the LV. So this patient is doing well thanks to the adaptation of the RV. And here he is again, but there are patients with Eisenmenger syndrome who don't do as well, who have different physiology. There are those who we call Eisenmenger AVSD, so a pre-tricuspid shunt with a very dilated and more impaired RV. We have patients with post-tricuspid shunts. This is a PDA Eisenmenger, but in her late 50s, you can see more advanced disease. The RV has lost its level of adaptation and prognosis is not that good. And of course, we have the patients with complex anatomy, and hence presentation prognosis depend on various things, on the age of the patient, of course, when you see the patient, when they present, but also at what stage of their condition they are, RV adaptation, response to therapies, comorbidities, and other factors. Indeed, the survival, the true survival of Eisenmenger patients is still not good over the years. In treatment-naive patients, this is beautiful data presented by Gerhard Diller, showing that Eisenmenger syndrome, which is down here, you see a patient in his 30s has a biological age of 62. So the prognosis of this patient is guarded even nowadays. And why is this? This is because the pulmonary hypertension, severe pulmonary hypertension, congenital heart disease, and the cyanosis increase morbidity and mortality, and we have a wide spectrum of. This is multi-organ disease. You can see the hematological issues, the heart failure and exercise intolerance, arrhythmias, infection, all contribute to the clinical presentation and also prognosis. Just a few slides to remind everybody that Eisenmenger patients are those with the worst exercise capacity of all patients with congenital heart disease. These are data presented by Alexander Kempny a few years ago. You see the median peak VO2, this is peak VO2 on cardiopulmonary exercise testing, is around 12 to 13 milliliters per cure per minute, which is close to what we would normally use for other patients to send them to transplantation. We do try to manage these patients. One of the things we do is to promote secondary erythrocytosis, which is there to increase oxygen carrier capacity to the tissues. And one of the way we do this very often in our center is by giving intravenous iron, which is safe in our practice, providing that you're careful in administering it, avoiding bubbles and paradoxical emboli. And we have not seen any excessive erythrocytosis or from iron. But what we have seen is an improvement in transfer saturations, in hemoglobin levels, and in a study performed by Edgar Tay with iron supplementation, these patients also exercise capacity and quality of life. Other complications that we need to deal with these patients is the progressive dilatation of the pulmonary arteries, which is progressive over the years and can lead to in situ thrombosis, which is present in over a fifth of our patients, probably a third, but also can have other complications such as atelectasis in this patient who, and also hemoptysis, which has led to her having heart-lung transplantation quite successful. This is what we want to avoid, of course. This is another patient with very dilated, progressively dilated pulmonary arteries in whom we didn't get to transplantation and unfortunately died due to a significant hemothorax. Now, if you look at data from the Nordic countries, you can see that the incidence, and of course prevalence of Eisenmenger syndrome is dropping in countries, in developed countries. Even though there is a plateau, I think we will still be seeing some Eisenmenger patients, the ones who miss their opportunity to be operated in a timely fashion. But also we need to remember that there are developing countries where the prevalence, incidence of and prevalence of Eisenmenger syndrome will be and remain much higher. This is an example of a paper that came out last year in 2019 from Pakistan, showing that patients who presenting in their adult congenital unit, a third had pulmonary hypertension, 16% had Eisenmenger syndrome, 41% cyanotic. So still a large number of Eisenmenger and cyanotic patients around in developing countries. Now, the mode of death, we said the mortality is high. What is the mode of death? The mode of death has changed over the years. You can see in the earlier reports that the hemorrhage, usually hemoptysis, and also periprocedural complications were the most prominent modes of death. Nowadays, it's more heart failure and infection. Indeed, we have learned a lot about how we manage these patients. We avoid complication. We avoid mortality from periprocedural complications because we tend to avoid any procedures in these patients unless absolutely necessary. There are, of course, other ways, other modalities of death, and these are beautiful data from the Anzen Hospital in Beijing, showing that patients presenting with pulmonary, in their center, pregnant with pulmonary hypertension. I will focus mainly on the Eisenmenger syndrome. You can see there was a 17% maternal death, which you could say is lower than the 30% or 50% we have been talking about in recent years. But look at the heart failure and other complications, very high instance of complications, so a very high risk group for pregnancy and delivery. And this is supported also by other studies, multi-center studies, where Eisenmenger syndrome, again, the mortality is 10%, but cardiac events 65%, and also emerging countries where had a higher risk of complications. So pregnancy is still contraindicated in these patients. How do we predict mortality in Eisenmenger patients? Lots of studies are published, including ours, on a walking test, showing that the 6-minute walk test can predict outcome, albumin, and BNP. We have shown that arrhythmias in patients generally with pulmonary hypertension, congenital heart disease, are a harbinger of adverse outcome, not only because of the arrhythmia itself, but also because the arrhythmia is a marker of advanced disease. But of course, we know that when a patient with pulmonary hypertension presents with an arrhythmia, you see that when the heart rate goes up, there's hardly no time for filling, and hence there can be sudden deterioration and even death in these patients soon after the onset of arrhythmia. This is probably one of the most important papers in Eisenmenger syndrome in the last several years. This is by Alexander Kepney, putting together a large cohort, over 1,000 patients with Eisenmenger syndrome, looking at prognostication and finding that these were the 5 most simple but powerful predictors of outcome: age, the presence of a pre-tricuspid shunt, so an ASD, Eisenmenger, oxygen saturations at rest, the 6-minute walk test distance, and presence of pericardial effusion. And using these simple markers, you can predict outcome in these patients. Other markers that you can use, of course, is echocardiography, and this is a paper from Circulation published a few years ago by our group, showing that this composite echo score that puts together various parameters, mainly of right ventricular dysfunction, is a strong predictor of outcome. This composite score contains TAPSI, but also contains this systolic-diastolic ratio, which you can see is mainly about filling time in diastole, which is more impaired in patients with RV dysfunction than in those with good RV function. And of course, right atrial size. Now, we know that PAH therapies do work in Eisenmenger patients. This is the BRIEF-5 with an improvement in pulmonary vascular resistance and 6-minute walk test. This is a seminal paper that changed our practice in this cohort. Recently, the Maestro trial study was published. The 6-minute walk test distance, which the primary endpoint, was not significant. But what is important in my mind is that NT-proBNP, which is an objective marker of disease, was significantly reduced by macitentan. So probably a therapy that we should be using. These are data from Greece, Italy, and Hungary, prospective trial of prostanoids in Eisenmenger patients as third line, showing a significant improvement in 6-minute walk test distance, BNP, and hemodynamics in this patient. So we should be using PAH therapies. We should be using in combination, even triple combination therapy, and prostacyclins should be considered, mainly treprostinil, subcut treprostinil in this group. And we should be using PAH therapies because there is some evidence of improved outcome from PAH therapies. These are data now published almost 10 years ago from our center, which have been verified, of course, by the group in Australia and also from Germany, showing that if you're treating your patient with PAH therapies, then you have an survival benefit. This is an interesting study, recently American study, that showed that even sudden death in Eisenmenger syndrome, the advance, so the use of pulmonary vasodilator therapies was independently and strongly protective against sudden cardiac death. So another reason to use PAH therapies in Eisenmenger patients. If we go beyond Eisenmenger syndrome, let's go to group B, the patients with left heart disease, with the left-to-right shunt, with the left-to-right shunts and PVR, which can be much lower than in Eisenmenger patients. And in these patients, you need to think whether these patients are operable. We now have guidelines to guide us with cutoffs, which differ between guidelines, unfortunately, but let's take the international PH guidelines. You see the 4 and 8 Wood units times meter square for PVRI that tell us whether the patient is operable or inoperable, and you have the gray group, gray zone of uncertainty in these patients. What you don't want to do is to close the defect when pulmonary vascular resistance is established, and then this can have an impact on long-term prognosis, as shown from this paper from Bologna and another paper also from Spain. This is an example to tell us that even baseline hemodynamics can be difficult to interpret. This is a 12-year-old with a VSD who was catheterized, and this is the PVR. You see that it is in the borderline gray zone on room air, and with nitric oxide still in the gray zone. You say, well, what do? It was decided to close the defect. You can see the closure device there, and the catheter was repeated a couple of years later. You would expect that closing the defect would have improved the hemodynamics. Instead, the PVR has risen now after closing the defect. So it is very difficult to use just hemodynamics to decide and to prognosticate on how patients will behave after defect closure. And of course, it's difficult to understand why other patients, like this patient with timely arterial switch repair of transposition of cardiac arteries, presents a few years later with very severe pulmonary hypertension requiring triple combination therapy with a very high PVR, who at the end had a successful heart-lung transplantation. In fact, transplantation is very important for our patients. We have been less successful perhaps in the UK than in other countries to transplanting these patients, mainly because the number of donors and the number of transplantations performed in congenital patients is small, certainly smaller compared to the number of heart failure admissions and the way these are increasing in our congenital population. Very few words on group 5, which is an interesting group which was inserted in the classification recently in 2018, the World Symposium. In group 5, multifactorial mechanism, complex congenital disease was added, including segmental pulmonary hypertension, the single ventricles of Fontanes, and scimitar, with a little bit of a question mark still. The segmental pulmonary hypertension, there is a paper where we defined with other colleagues around the world and classified segmental pulmonary hypertension, the prime example being complex pulmonary atresia with areas of hypoperfused but also areas of pulmonary vascular disease within the lung. Now, there is some evidence that PAH therapies may work in these patients, but there is still a lot of work to be done to understand this condition and its management. The Fontan, of course, is very important. We have an increasing number of Fontan patients who have various degrees of central venous congestion, and of course we want to be giving them PAH therapies in theory to reduce pulmonary vascular resistance and increase flow and cardiac output. There are some studies, there is some evidence that PAH therapies may work in these patients, but looking at the UK practice, this is data from Andrew Constantine's work with various centers, almost all centers around the UK, collecting data on over 1,000 Fontan patients and matching them between patients on PAH therapies and not on PAH therapies. We found that only 6% of patients had been starting on PAH therapies, and when compared the two groups, we found that the physicians feel still the need to have strong indications for starting PAH therapies, such as severe heart failure, ascites, low albumin, and refractory to treatment, so proterolysis enteropathy. So still not prescribed to all patients. Finally, to say that one of the most important things we can do for improving the prognosis for our patients is education. Education for our patients, and education for doctors and healthcare workers in this field. Part of this education is the structured transition of patients from pediatrics to adult services. It is important, of course, we screen all patients with congenital heart disease for pulmonary hypertension. We published a paper for the non-experts on how to do this for patients with more complex disease. And of course, we need to be working on heart transplantation and having this option for more of our patients. This is a beautiful paper by Pablo Meras and Professor Gatzoulis, highlighting the need for more transplantation. We will be talking about this later on today. Thank you very much.
Thanks a lot, Kostas. That's terrific. Cover in 20 minutes. David, do you want to lead these?
Yeah, that would be great. Kostas, that was, as expected, spectacular. Thank you so much. Can I ask, if you see a new Eisenmenger in your clinic, say a 25-year-old woman with an Eisenmenger AVSD, what's your routine first-line therapy? As you know, in non-congenital heart disease, PAH, combination therapy is now routinely commenced. And you touched on it very briefly and said that sometimes even triple therapy is recommended. But in your clinic, what's your approach to a newly diagnosed Eisenmenger?
So first of all, we would risk classify a patient who, as you said, an AVSD Eisenmenger patient can have very impaired right ventricular function. We'll look at the 6-minute walk test, the BNP, and if this is truly advanced disease, we would probably go for early sequential therapy. We don't. If, of course, is in extremis, is really unwell, we would consider intravenous prostacyclin or in other centers subcut, but we generally try oral therapies first of all in these patients. It is important that these patients are catheterized. They are not like the VSDs or the PDAs where we can assume the diagnosis, even though I think most of our patients should, if there are any doubts, receive cardiac catheterization. But it's all about risk stratification. And if the patient is truly unwell, while we're waiting a few weeks for therapies to work, even early sequential, so starting one therapy and then the next within a few days, I would start speaking to my transplant team to make them aware of these patients in case things don't go the right way.
There's a question from the floor, David. Do you need to go, David? It seems, no, not yet. Okay, it's wonderful to have you with us, and it's amazing, so much opportunity with technology for all of us. But there's a question from Stephanie Curtis from Bristol, Kostas, and colleagues, that she thinks patients with PAH and AVSD, that the AVSD is a bystander, and that's why maybe we see different clinical phenotype as presented by the large study that Alex Kempney sort of headed. Would you like to comment, Kostas?
I think this is a very good question by Stephanie. There are lots of colleagues who would call AVSD Eisenmenger. They would call it idiopathic with an AVSD. We tend to call it Eisenmenger AVSD just to remind ourselves that this is number one. If the patient presents, of course, with very severe pulmonary vascular disease, there is right to left shunting. We see lots of pulmonary artery dilatation. So all the spectrum of the phenotype of Eisenmenger patients. So it is more for us to remind ourselves that we should be following many of the rules that we follow for Eisenmenger patients. Now, whether you want to call it idiopathic with an AVSD, it really doesn't matter as long as we are vigilant for all the complications and also vigilant for expecting and promoting erythrocytosis or if the patient is cyanosed. So yes, it's a matter of nomenclature, but at the end of the day, the physiology is similar to Eisenmenger patients. That's why we call them Eisenmenger.
Thank you, Kostas. And we'll have more on this subject tomorrow. Teiji Akaji from Japan is joining us on the plenary PAH session. So Stephanie and colleagues, please stay with us. I think we need to move on, Kostas. A terrific contribution. Appreciate it very much. David, I'll introduce